I would also like to thank the organizing committee and especially Professor Kotsis for the invitation in this very interesting meeting about metabolic disease. And also would like to thank him about the topic of my presentation, because I work a lot with patients patients suffering from obstructive sleep apnea, and there is a very close association of this disease with the cardiovascular system. So there is evidence that there are normal cardiovascular changes in sleep. And as you can see the figure, during non-REM sleep, there is decreased sympathetic activity, increased parasympathetic activity, and this results to reduced blood pressure, heart rate, cardiac output, ventilation, and metabolic rate. That means that there is a cardiovascular quiescence during non-REM sleep. On the other hand, during phasic REM sleep, there is an increased sympathetic activity with increased blood pressure and heart rate. So this means that there are diurnal variation in blood pressure, in heart rate, and cardiac events during normal sleep. However, if someone suffers from a disease like sleep apnea, this disrupts the normal sleep-heart interaction. And also we should have in mind that cardiovascular events are more likely to occur at certain times of the day. So there are also diurnal patterns in cardiovascular conditions like sudden cardiac death and ischemic episodes. And these happen during early morning hours. And these could be due to the autonomic fluctuations during REM sleep and the predominance of REM sleep during the early morning. And also the early changes in blood pressure, cortisol levels, and inflammation and thrombotic markers are also have this pattern. So for you that are not really involved in sleep medicine, obstructive sleep apnea is the most frequent sleep-related breathing disorder that is defined as the obstruction, partial or complete, of the upper airway, and there is an ongoing effort to breathe. And the severity of sleep apnea is defined as mild, moderate, and severe, according to the apnea-hypopnea index, that is the number of apneas and hypopneas per hour of sleep. So sleep apnea is not a really rare disease. And as you can see, there are millions of people suffering from the disease all over the world. And also there is evidence for many, many years that sleep apnea is an independent risk factor for all-cause mortality. And the more severe the disease, the higher the probability of dying from it. As you can see in this figure, these are the pathophysiological consequences of sleep apnea syndrome. So during sleep apnea, there are cycles of apneas or hypopneas and their recovery. And these lead to episodes of hypoxia and hypercapnia. And these result to decreased oxygen delivery, leading to organ dysfunction as heart dysfunction. They lead to oxidative stress and inflammation, leading to endothelial dysfunction. Hypoxia and hypercapnia result in hypoxic and hypercapnic pulmonary vasoconstriction that results to increased right ventricular afterload. And also hypoxia and also the arousals result in sympathetic activation and parasympathetic withdrawal, having as a result the increased blood pressure, arrhythmias, myocyte toxicity, and increased heart rate. Also during an apnea, there is a decrease in pleural pressure, and these results in increased transmural pressure of all cardiac chambers and the aorta, and also increased pulmonary capillary hydrostatic pressure. And these lead to increased ventricular afterload, arrhythmias, aortic dilation, and increased lung water. So these are the factors that have an impact in the cardiovascular system. However, we should remember that there are also metabolic consequences of this disease. There is decreased insulin sensitivity, there is increased lipolysis, impaired lipoprotein clearance dysfunction that lead to diabetes and dyslipidemia. So all these factors affect the cardiovascular system. And also there are the non-cardiovascular consequences like daytime sleepiness, decreased quality of life, and decreased memory, increased depression symptoms that all have an impact on the quality of life. So there is a high prevalence of sleep apnea in patients with cardiovascular disease. And you can see that the prevalence in hypertension, coronary heart disease, stroke, heart failure, and arrhythmias. And we should keep in mind that patients with sleep apnea have a high burden of cardiovascular disease, and not only the disease that are clinically evident, but also there is a significant association between sleep apnea and markers of subclinical cardiovascular disease as endothelial dysfunction and subclinical atherosclerosis. So these patients should be offered treatment maybe more aggressively in order to protect them from cardiovascular risk. It is well known that obstructive sleep apnea is highly relevant to patients with hypertension, and these two diseases frequently coexist. And again, it's known that there is obstructive sleep apnea is also the most prevalent secondary contributor to elevated blood pressure in patients with resistant hypertension. I don't have a marker, so. And as you can see, the more severe the disease, the higher the incidence of having hypertension. And it is well known that the odds ratio of having hypertension increases as the disease of obstructive sleep apnea is more severe. And this also exists if the results are adjusted for age, BMI, alcohol, cigarette use, and all those factors that affect the cardiovascular risk. What about symptomatic patients and non-symptomatic patients? There are patients with sleep apnea that are not very sleepy. So it has been shown that these patients are not at as great a risk for having hypertension, for developing hypertension, as those who are sleepy. Apart from hypertension, there are also other cardiovascular diseases that are affected from sleep apnea. And as you can see, there are arrhythmias like atrial fibrillation, heart failure, and coronary artery disease. So as you can see in this very well-known study, there is an association of sleep apnea with mortality, with cardiovascular events and strokes. And the more severe the disease, the greater the hazard ratio of having these problems. And also there is an association of sleep apnea with aggravation of heart failure. And I described before the pathophysiologic mechanisms of sleep apnea. And all these mechanisms, like the intermittent hypoxia, arousals, and the decreased pleural pressure, may aggravate the existing heart failure. With the decreased oxygen delivery, there is further heart dysfunction. With endothelial dysfunction syndrome, there is a vasoconstriction, thrombosis, and inflammation that aggravate heart failure. Also, with hypoxia and hypercapnia, there is pulmonary vasoconstriction. And again, with sympathetic activation, it again increases the blood pressure and increases the adverse effects on heart failure. And again, with the decreased pleural pressure, again, there are changes in the right and left ventricular afterload, and also there is increased lung water. So all these may aggravate the existing heart failure. And as you can see in this older study, there is a high prevalence of sleep apnea in patients with heart failure. And you can see in the blue the patients with low ejection fraction, and in red with normal ejection fraction, the obstructive sleep apnea is about 25%. And as you can see in the other figure, when these patients are tested, diagnosed, and treated, they have better survival. What about arrhythmias? It's again very well known that obstructive sleep apnea affects the electrical remodeling of the heart, and all these features that are included in the pathophysiology of the disease may affect the autonomic nervous system fluctuations, leading to a cardiac electrical remodeling. And like that, there is more patients with sleep apnea have more prevalent arrhythmias. What about pulmonary hypertension? Again, in the pathophysiology of the disease, I showed you before that the apneic events with a negative intrathoracic pressure and also intermittent hypoxia, also the hypercapnia, are related and aggravate the dysfunction of the right ventricle. These are the precapillary effects of sleep apnea in the development of pulmonary hypertension. And also there are the postcapillary mechanisms. When there are negative in the thoracic pressure, there is an increase in venous return, leading to the leftward septal deviation, reduced filling of the left ventricle, increased pulmonary pressure, and again the chronic effects with the sympathetic over activation, the systemic hypertension also affects the diastolic dysfunction of the heart, leading again to pulmonary hypertension. And it has been found that these patients that have acute heart failure with pulmonary hypertension and also suffer from sleep apnea, obstructive sleep apnea, when they are treated with CPAP, they reduce their pulmonary pressure more than those who receive treatment only with diuretics and oxygen. So we should keep that in mind for our patients. What about incident stroke? It seems that we have also to keep that in mind in our patients because it seems that male patients are at higher risk than females. In this study, it was found that with male patients with mild to moderate sleep apnea have higher risk of having a stroke, and on the other hand, women are at higher risk in higher severity of sleep apnea. What about the coronary heart disease? It's a very the worse the severity of sleep apnea, the greater the hazard ratio of suffering from incident coronary heart disease. So we should also keep that in mind for our patients. And what about treatment? Respiratory medicine doctors, we use, and during the pandemic there was a great use of CPAP, continuous positive airway pressure for our patients. CPAP is the gold standard for the treatment of sleep apnea. And can this be used as an antihypertensive agent? You can see these studies here. They are a meta-analysis of randomized controlled trials, and the blue is the systolic blood pressure, the red is diastolic blood pressure, and you can see that in most of them there is a reduction of blood pressure, and the last one includes only patients that are non-sleepy. So the effect is not the same in these patients. What about resistant hypertension? Again, you can see that there is a reduction of blood pressure in most of the randomized controlled trials and meta-analysis. So we should keep that in mind. This is the PARCO randomized clinical trial. That's a very famous trial that assesses the effect of CPAP on blood pressure in patients with sleep apnea and resistant hypertension. And if you can see in these small numbers, there is a reduction of blood pressure when the patients were using for 12 weeks CPAP. And it has been found that the effect was more evident in patients that were deepers, had the deeper pattern of hypertension. And in this post hoc analysis of this trial, it seems that patients that suffered from refractory hypertension had the greatest degree of reduction of blood pressure. What about non-sleepy patients? As you can see in this figure, in the first figure, this study found that there is no significant effect in the blood pressure of patients that were not non-sleepy. However, when they analyzed more their results, they found that patients that were using their CPAP device more than 4 hours had the best effect of the device. So there was a reduction of hypertension or cardiovascular events in those patients that used the device more than 4 hours. And which patients would respond better to treatment with CPAP. As I showed you in all the previous studies, the reduction of blood pressure is about 2 millimeters of mercury. You can't compare it to the medication of antihypertensive medication. However, even the 2 millimeters of mercury decrease has a significant effect on cardiovascular events and the mortality of patients with hypertension. So the phenotypes that had showed the greater response in CPAP were those who were younger, had uncontrolled blood pressure at baseline, and also had the greatest oxygen desaturation. These patients had the phenotype that predicted the best response to CPAP. And something that we should all keep in mind is that the CPAP device promotes the significant increase in BMI and weight. So someone doesn't really expect that. And excess weight really affects the cardiovascular system. So when we are treating our patients with CPAP and they are overweight or obese, we should offer them additional therapies for body weight reduction. So we should always think about that. And as you can see here in this study, when CPAP plus weight loss were used, the effect in hemodynamics and arterial stiffness, the red column, was much better. What about the other cardiovascular risk and the effect of CPAP treatment? You can see that in all the studies, apart from the SAVE study, that's the one, not the last, the one before the last column, had showed an effect that favors CPAP, and the blue is the intention to treat analysis, and the red box is the adherence analysis in patients using the device more than 4 hours. And this is the SAVE study, sleep apnea cardiovascular endpoints clinical study. This study showed that treatment with CPAP plus usual care as compared to usual care alone did not prevent cardiovascular events in patients who had sleep apnea and also suffered from cardiovascular disease. However, if you read this paper, you will see that there is a low compliance of the device, about 3.3 hours. And when the analysis when they analyzed further in patients who were adherent or not to CPAP, they found that those who were adherent to CPAP had lower stroke risk. And also, we should keep in mind that CPAP significantly reduced the quality of life and reduced snoring of these patients. So it was not useless. When it was used, it had a very significant effect. What about stroke? It seems that when CPAP is used with good compliance, it can reduce the risk of stroke in patients with sleep apnea. And also, what about the non-sleepy patients with coronary artery disease? In this paper, you can see in the Regatta randomized controlled trial that they found that there was not a very significant reduction of cardiovascular outcomes. However, if the results were adjusted for baseline comorbidities and the compliance to the device, they found that the more patients used the CPAP device, the less adverse cardiovascular events were in this patient that suffered from coronary artery disease. What about the patients who had atrial fibrillation and they were treated with catheter ablation? It seems that the use of CPAP reduced the risk of recurrent atrial fibrillation. So if we have a patient who is going under this treatment, we should check them for sleep apnea because they could probably have a recurrent episode of atrial fibrillation if they suffer from the disease. So in conclusion, I think I have persuaded you that there is a very close relation between sleep apnea and the cardiovascular system. And because I know that you're not all somnologists or you're not working in a sleep lab, I'm really, really pleased that during the last years, there are people, there are doctors out of the respiratory department, or especially cardiologists, or even doctors from the primary care that refer patients to our sleep lab because they they have resistant hypertension or pulmonary hypertension, or because they have recurrent atrial fibrillation, or they have elevated cardiovascular risk or arrhythmias, and there is a suspicion of sleep apnea. So I think we are getting better and better in the diagnosis of sleep apnea, because if it is treated, there is a significant reduction of cardiovascular risk. Thank you for your attention, and I'm waiting for